Good afternoon, everyone. Welcome to today's Indians program. Today, we have with us Dr. Suresh Bada, who is Professor of Psychiatry at NIMHANS. He's also Head of Forensic Psychiatry Services and Telemedicine Center at NIMHANS. He's also consultant in community psychiatry at NIMHANS. He is also President-elect of Telemedicine Society of India, Karnataka State Branch. So welcome you, sir. Today, he'll be taking a session on prison psychiatry. Uh, Before we begin the session, we also have a YouTube channel. Kindly subscribe to our YouTube channel, NIMHANS Indians, to get all the updates of all our videos which have been currently taken for these sessions. We already have 33 sessions, academic sessions in our program, Indians. So welcome you all again. Sir, over to you, sir.
Okay, thank you. Today we will be discussing on prison psychiatry, basically prison mental health. Myself, Dr. Suresh Bada. I am head of Forensic Psychiatry Services and also Telemedicine Center. And also I am looking after the consultancy community psychiatry, and I'm teaching at National Law School and also training at Judicial Academy. And this prison study which we had done was done in 2010. So these are the contents what I'm going to do the presentation. So this is what the study which we had done, that is mental health and substance use, problems in prisons, local lessons for national action. So if you look at the prison was, earlier it was a reactive, that somebody has done something wrong, we have to do something wrong to him. That is basically punishment. That was the basic agenda which was started. And later it became, no, we not only punishing him, it is a deterrence to the society. So these are the two ways which was planned, and the prison, what we call it as establishment, was started. Later, over a period of time, no, it's a reformation, because once you are given the punishment, he is coming out to the community. So once he comes to the community, how he is going to contribute to the community makes a large difference. So then the proactive rehabilitation process started. So this is how the prison of a, what we call it as a welfare society, moves forward. If you look at the mental health morbidity in various prisons, there are various studies available. I am going to quote only few studies. One of them is from Rajasthan, which clearly, which did a random sampling of 118 prisoners and came out telling that 6% had psychosis and 16% had depression. Anxiety disorder was 8%, and the drug abuse was very high. This was published in IJP in 2013. Similarly, a study done from Kerala also looked at 255 prisoners. Basically, these are all convicted prisoners. In that, 175 prisoners had some or the other mental disorder. And one of the important finding here, we came to know antisocial personality disorder was around 19% actually. So that's a huge number. That is, we are talking about around 20% of the prison population having ASPD. Basically, they are very difficult to change, but they do very well in a structured environment. At the same time, they also came up with mood disorder having 4%, psychosis also around 6%, similar to the previous study. So this is how the various studies have come up, and also the Punjab prison study, which was one of the, again, none other than the Dr. Goyal Saab, who is very well known from Amritsar, did a convicted prisoner study and came out that 23% had one or the other psychiatric disorder. So these are the various studies which in India about the prison study which talked about. Even at the international level, the Lancet publication in 2002 spoke about 40 to 70% having a point prevalence of mental disorder. And this is a meta-analysis study. It's one of the best study, I would rather say, and it is worth going and looking at this study. Coming to the, what are the possible hypotheses why we have increased mental health morbidity in the prison. So first and the foremost, it may be a petty crime. And because of that petty crime, he is punished. It may be just what we call it as mobile phone theft or something, mugging may be there, and he's punished. He has taken to the prison. In the prison, he will be in contact with the organized crime. And from there, when he comes out, he's not been given any employment. And again, he's going to organized crime. So there, we call it as university of crime establishes. More than what we are telling that prison to be deterrence or the reformative, it's becoming more worse. The person who enters to the prison is a unorganized sector. He becomes into an organized, what we call it as a criminal gang. He starts working for those big gangs. And if you look at the one of the other issue which we can talk about is the Penrose law. Basically, I'm trying to say here is in Penrose law, Mr. Penrose says that the when the rights of a person with mental illness is given very high, and then the person refuses to take treatment, especially during prophylaxis, and then he has a relapse. During relapse, he may become violent, and during this time, what happens is because the society is not what we call it as prepared for this violence, they do consider giving a police complaint, and then the person ends up in a prison. So the prison population is inversely proportional to the what we call it as mental hospital asylum. That means if the population of mental asylum is more, the prison population decreases. If the mental asylum population is decreased by various means, by telling that no, we have to deinstitutionalize, and we allow the patients to go out maximum in number, and there is no community care, invariably what happens is they end up in a small petty crime, and they will be arrested, and they end up in prison. And invariably, once they are into the prison, the people who are going to fight for them will be less. And now coming to this, if you look at the person with having aggression, domestic violence, public nuisance, or what we call it as illegal activity, and especially substance use. For example, across many countries, substance use, especially illegal substance, what we call, is a punishable offense. These people who are using them, one is trafficker, the person who uses are also punished. Example, in our country, under NDPS Act, even a user is punished. The user is arrested, taken to the prison, and in the prison again, you are not going to address for his substance use. And then he will be again, there is no any de-addiction treatment available in the prison. And once he comes out, again he will be using substance, the crime continues. Or a person who is having delusional disorder, he goes, because of his violence towards his wife, he goes to prison, it is untreated, he comes out again, the same thing continues. Alcohol use, name the substance use, he goes to prison because of in the intoxication state, he does something, goes to the prison, nothing happens there, no treatment is available, comes out to the community, again it continues. So recidivism or reoffending behavior increases. So these are the various hypotheses has been put forward why the prison population, the mental illness morbidity is high. That's one. And also the realistically, if you check what happens in prison, especially in a developing countries, the prison population is very high. Basically, the number of people who should be in the prison is the accommodation is very less. For example, in India, it is somewhere around 4 lakh population is the which can be catering for the prison population. But actually, when they have done the study, it is around 4.5. That is 4.5 lakh people are in the prison. But again, in the 70% of them are all under trial prisoners, in spite of people are getting what we call it as bail. And especially the bail is given very commonly, especially for women, and also the people who are not have done the crime, which is what we call it as cognizable offense, the bail is given. But in this scenario, which where the bail has been given so easily, the prison environment, which requires to be around 4 lakhs, now we have around 4.5 lakhs. So it is overcrowded, and some prisons are so much overcrowded. In a barrack, there will be huge number of people with overcrowding and with communicable diseases, and various other issues starts manifesting. So this is, in this background, a study was planned. The study name was Mental Health and Substance Abuse Problem in Prison, and this was planned in Bangalore prison, the central prison. And again, the whole reports are available. It has been published in 3 booklets. One is in the report of the prison study of Bangalore, local lessons for national action, and substance use, that executive summary was also there. And then the review of the minds imprisoned, it is available on nimhansco.in. If you go there, you will get all these, which is freely downloadable. And even WhatsApp, we have circulated this study reports. So this study consisted of Dr. Suresh, that is myself, Pratima Murthy, the HOD of currently the Department of Psychiatry, NIMHANS, Rajini Parsarthi, she was the prison psychiatrist at that time. Currently, she is working as a deputy director for Karnataka state government. C. Navin Kumar, professor of psychiatry in NIMHANS, and Madhusudan is in from Bangalore Medical College. Along with this study was funded by High Court of Karnataka from Karnataka State Legal Service Authority. Basically, at the time, during that 2009, when the study was discussed, Honorable Shri Justice Jagdish Singh Kher was the person who allotted the money, and then he became Chief Justice of India. So there were very visionaries. Even Honorable Srimati Justice Manjula Chellur ma'am was also here, and she was the backbone behind the study, and various other people supported our study. At the same time, from the Department of Prison, S.T. Ramesh sir, he was also gave us a full freedom to do the study, and he was the main person who initiated this study. And subsequently, during the study of around 2.5 years, the number of prison IGs changed over a period of time, but however, the study never stopped. And also there was an expert committee was formed, which consisted of director of NIMHANS and also various experts from BMC, Bangalore Medical College, and also joint director Vishal Karur and Dr. Kishore from Chennai Banyan, and Professor B.N. Gangadhar sir was also the expert committee person. And this study was considered because at that time there was various issues were happening. The suicide inside the prison, substance abuse inside the prison, and a couple of issues which happened led to the study. And S.T. Ramesh sir became the prison IG, and he said, why not do a mental health checkup of all these prisoners and to know what is the mental health attitude of these prisoners. In this background, this study was planned. This is where the Central Prison Bangalore, the study was planned, and also it was a newly formed prison. In 1997, the prison, the location from the heart of the Bangalore, it was moved outside the Bangalore. And again, this was the methodology of the study. The study was conducted in 3 phases. The first phase was assessment of the prisoners. There were around, when the study was completed, we have assessed 5,024 prisoners were assessed, both under trial prisoners and also convicted prisoners. At the same time, we also plan to do anonymous urine screening of the prisoners to know what is the substance use. The second stage, what we planned was mental health training of the program of the prison staff, because there were around 5,000 prisoners, but the capacity of the prison which was built was hardly 3,000. So, and also the staff were also very less. And at that time, there was no what we call it as a provision to have a mental health professionals inside the prison as a staff. So we had to rely on their staff for training. And also at the same time, when the study was ongoing, when we were systematically assessing the prisoners, the staff were becoming jittery. They're telling that you are assessing for the prisoners' rights have been given so importance, but not the staff. And immediately we called for an amendment. The High Court of Karnataka was so generous. They increased the funding and also said, please do the assessment of the prison staff. What is their mental health morbidity in them? What are their concerns? And that part of the presentation I'm not dealing today, but however, that is an interesting study where out of 250, 201 staff participated in the study, and that I will be discussing in a separate presentation, but today it will be only on the prison. And at the same time, we came up with the development of the guideline, and the dissemination of the project was planned. And the assessments, what we did was, first and the foremost was collecting the socio-demographic data. Audit was used, lifestyle questionnaire, and mini was the Sheehan et al. Which we used, and also needs assessment questionnaire. General health checkup also was done across all the 524 prisoners. And the protocol was submitted not only for NIMHANS Ethics Committee, it was submitted to High Court, Karnataka State Legal Service Authority, IG Prisons. All 3 departments went through the, what we call it as the protocol. It was discussed extensively. One of the issue which came was the couple of judges insisted that when we do anonymous urine screening, those people who are tested positive under NDPS Act, they should be notified to the High Court. But however, after the discussion about the ethics, and then we said many prisoners who inside the prison may not voluntarily participate in the study. And finally, we got a sanction of telling that, yes, go ahead with anonymous urine screening, and we started the study. And this study was again inaugurated in the prison premises, and it was inaugurated by the governor of Karnataka at that time. And then the study was launched. And the procedure was a universal sampling was the plan we did. The reason being is we had 5,000 prison population. Every day, 50 prisoners used to come inside, and another 50 to 60 prisoners used to go outside by bail, or they have been acquitted from the crime. So we had a huge floating population, and we had to hire a researcher, and we had hired the researchers, and they underwent a rigorous training both in NIMHANS and Bangalore Medical College, and all the tools which I mentioned were translated in Kannada. And all the written consent was taken from all the under trial prisoners and also the convicted prisoners, and the consent form was used in the language which the prisoner was comfortable. And the study started moving from one barrack to another. The reason being is there are 5,000 prisoners inside the barrack, and we started from one barrack to moving to the other barrack. So the prisoners are covered. But unfortunately, by the time we finished 1 year, there were more than 6,000 population moved in and out of the prison. And each assessment carried for 1 hour, and a separate prison research room was allotted, and no prison staff was allowed inside there, and it's only the prison research staff used to do the assessment. All positive cases which were on the screening was interviewed by the prison psychiatrist, that is none other than Dr. Rajini Parthasarathy, and she confirmed the diagnosis. And it took almost 11 months to complete the assessment of all 5,000 inmates. At the same time, we had to do a urine analysis. It was a random sampling we planned, and we randomly chose the barrack. There were n number of barracks. It may be around, I think, 26 or 27 barracks were there. Randomly, the barracks were chosen, and we visited the barrack and requested for urine for testing. And the health camp was conducted inside the barrack, not in the hospital of the prison. There is a prison inside the hospital, but instead of calling all the prisoners to the hospital, it will be not feasible because 5,000 and the prison hospital is very small. So we had to go to the barrack directly, and we started doing general physical examination. And these are the photographs. Because of the what we call it as confidentiality, I have morphed the what we call it as photograph. You can see the prison population who participated. This is a barrack, actually, prison barrack. And on the one side, all our doctors and the staff who are providing healthcare were seated, and they were doing. At the same time, the prison population were standing, and they were undergoing checkup. So there was active participation both from the staff, both and also from the prison, what we call it as inmates. And these are our doctors who were participating, and we were doing a urine test. And the doctor, you can see Dr. Rajini, and urine analysis for sugar, protein, and also we used cassettes for urine for the drug substance. For 6 substances were checked for. At the same time, we also started using the breath analyzer for alcohol, and also for the tobacco. Carbon monoxide was done. And you can see Professor Pratima Murthy sitting in the barrack of the prison. And also at the same time, the second phase also initiated. Staff training was conducted at the central prison in Bangalore and Mysore, because we had to provide a care for 5,000. And imagine, in 5,000, when the study was being done, there were, I think, 3 suicide. One was a prison staff who committed suicide within the premises of the prison. At the same time, also the 2 prisoners committed suicide. So we had to immediately switch over to phase 2 to start the training of the prison staff. And at the same time, we realized the 2,000 prison staff is very small for 5,000. Then we looked into the population, what we call it as prison inmates. There were many prison inmates who were convicted prisoners, who are educated, who are motivated, who wanted to do something good for the society. This is basically the prison staff who are undergoing training. These are the jailers and the prison staff who are actively participating. Dr. Rajini was involved in the training. Here what we did was group discussion. A problem was given. If they find a prison inmates having substance use, how they will deal. If a prison inmate is contemplating suicide, what they are planning to do, or how they are going to deal. Such kind of discussions were held here. And then the illness, mental illness, depression were discussed. And we used audio visual for doing staff training inside the prison only. And these, again, we used prison convicted prisoners who were motivated. They were trained actually as a peer support, what we call it as a gatekeepers training for suicide and depression and substance use. And these actually became the army for us to what we call it as the screen the patients or the prison inmates, whoever today, for example, maybe in couple of barracks, there are around 4 or 5 prisoners did not get bail. That is the high time when they are most probably may attempt suicide. So there were what we call it as a red flags were marked, and then these the people who the people prison inmates basically who underwent training were given what we call it as training, and they went inside the prison and they were able to know who are the prisoners who are high risk for suicide or depression or a substance abuse. This is again present the staff training in Mysore. This is Dr. Naveen who is doing training. And at the same time, again, the various, what we did was doing a group discussion along with the convicted prisoners. And then the amendment was done, as I told, the staff had to be trained. And the staff assessment was also done. 1 month extra, we did the study. Staff cooperated in the project. And this is the superintendent of the prison, and he became later the ADJ, IG also he became, and then they also took the project as a ownership for their study. And if you look at the study report, has a beautiful diagram of a tree along with the leaf. This was again, what we did was to have a cover of photo for this. We had a tray, what we call it as a drawing competition inside the prison. And then one of the prison inmate got the first prize, and she was honored with the, actually she was a lady, she was honored with the certificate from the governor of Karnataka. And then this is the drawing competition which was going on for the cover for the report. And the phase 3 data entry, data analysis, interpretation of the finding, and documentation and also dissemination of the report was planned. The results, I'm not going to the complete depth of the results. I'll be giving only the highlights of the results, and you can find those, the complete report will be available on these reports. Please go there and read about the report. First and the foremost, I would rather give you 5,200 prisoners were there, 248% occupancy, 65% is UTP. And if you look at the national average, even in India, out of 4.5 lakh, 70% of them are under trial prisoners. Only 4%, 4 to 5% are women. And when we did the study, 80% of them had mental illness, 80%. And if you excluded the substance use, maybe tobacco, alcohol, or other drugs, it became 28%. And approximately 2% had severe mental disorder. Look at the urine screening. So urine screening we did for more than 1,600 actually. And we divided the urine screening for the new entrant and the people who are already there for more than 1 month to know the incidence and also the prevalence. That is the way we would like to look at it. The new entrants, when the person who entered the prison, when we did the urine screening for substance use, 45% were using drugs. And if we do this urine study for the population who were already inside the prison, it was 61%. That means from 45% it shifted to 61%. Look at the urine cassette positive. 28% were positive for benzodiazepine, and inside it became 43%. Then we actually looked into the benzodiazepine prescription pattern inside the prison. But the doctors, again, the utilization of the benzodiazepine was very less. But however, later we came to know that benzodiazepines were smuggled inside the prison through various means. It may be family member, it may be a prison person who is coming, and maybe some of a couple of prison staff may be involved. It was very difficult, and many a time these substances were stuffed into a rubber ball, and the ball was thrown across the barrack towards inside the prison. Look at the cocaine. It was 70% when they came, but however, it became 15% later. If you look at the cannabis, it was 13%, but it becomes 31% as the day goes on. Amphetamine was 4%, and it became 6%. And opioid was 1.2%, and also the opioid became 3%. So that means the substance use was high inside the prison. So that was one of the finding which was very difficult to accept initially, and later when we looked into the various other parts of the country and also various other the prison, there is no prison which is untouched by substance use. Substance use is present ubiquitously in all prisons, but the one of the way to know the yardstick is the cost of substance use inside the prison. If the cost between the general population and the prison, if it is almost same, that means the substance is easily smuggled inside the prison. If the cost of the substance inside the prison and the general population, if you look at the outside in the community, if the cost is very high, that means the prison is doing a very good job. The drug is not smuggled so easily. So you cannot stop the drug abuse inside the prison. It's very difficult. We can do any number of what we call it as measures, countermeasures you can do, but still the substance will be smuggled inside the prison without our knowledge, and it may many a time various mechanisms they have developed. And alcohol use was 44% were ADS when they committed the crime, and many of them accepted that they were intoxicated, only 14%, and 4% said that we had alcohol inside the prison 1 week back. Depression, when it was seen, 12% had a past history of depression. 9% when the study was done had the what we call it as depression, and 2% attempted, and 2 prisoners completed suicide along, and one of them third person was a staff. So 2 prisoners and 1 staff completed during the 1 year period, and 7% had DSH attempt. 7% is equivalent to into 5,000. It's a huge number what we got. It may 70 into 5, so 350 people had had a DSH attempt in the period of 1 year. Psychosis was 2%. Antisocial personality disorder, the same way what they found in Amritsar study, we had 15, they had 19%, we had found 15%. This again, we used a mini version of dissocial personality trait, how to look at it. We found 15% of them had antisocial personality disorder. That means 85% can be rehabilitated. So that's the finding. I would rather put it in a the other way. And till now, this is the results. And this, once the study was completed and the study was disseminated, we were unable to publish this. The simple reason was this study was immediately made as a writ petition, went into the Supreme Court. And when it is in the sub judice, we cannot publish that. And anyhow, by the time we are able to publish this as a report and was submitted to the High Court of Karnataka, from there it was taken to the Supreme Court. So since it was sub judice, we could not. But later, there was a series of judgments which came in. At the same time, looking at this study also, the Mental Health Care Act also shaped. In the Mental Health Care Act, if you look at the section 103, it clearly says every prison should have a medical establishment inside the prison. And there, the prisoners need to be treated inside. And if you want to shift the person from the prison to a mental health establishment, MHRB permission has to be taken. And for every 500 prisoners, there should be a 20-bedded psychiatric facility should be there. Telemedicine facility should be available. Psychotropic medicines were clearly ruled, what we call it as clearly mentioned. 24 oral medicine, 7 injectables were clearly written in the schedule, so that these are the medicines which were made essential to the prison: risperidone, olanzapine, clozapine, and also similarly acamprosate, naltrexone, disulfiram, nicotine gums. So all these medicines were made, should be made available, and the schedule under the rules were made, and it was gazetted. But unfortunately, nothing happened. But however, there was a landmark judgment which came in 2019, 12th April. This is Accused X versus State of Maharashtra. In this case, Mr. Accused X is a person in 1999. In December, in the evening, he goes out, and when he's buying something from the nearest grocery shop, he finds 2 small kids. One is studying 1st standard, another studying 4th standard. That's hardly around 6 years and 7 years, 6 years and 9 years. He takes both the kids into the nearby place, nearby outside to the farm place, and he rapes both the kids, and he murders them. Actually, he kills them. And finally, when the locality comes to know about this, and then he accepts that he has done the rape and he has murdered, but he had some kind of mental illness. But the insanity defense was not used in the district court. He was given a life sentence, and also in the high court it has been considered to be a, what we call it as, he has to be given a death sentence, and then it goes to the Supreme Court, and again in the Supreme Court telling that he is mentally ill, he should not be given death sentence. And then this discussion goes on, and it comes in 2019. The Supreme Court was very clearly and categorically said that though the defense was not used in the early period, so he will not be given insanity defense, section 84 IPC. During the way the crime was committed, he cannot get the eligibility of section 84. He is not so severe, but however he has mental illness and he needs to be treated. And there was a psychiatrist from Maharashtra who goes to the court and gives the expert opinion. And during that time, the Supreme Court clearly said that all state government should implement Mental Health Care Act, and the medicine should be made available, the provision of the central rules to be implemented. Subsequently, if you know, many of the state government came up with the guideline clearly telling that psychiatrists need to be hired in the prison, psychologists need to be hired in the prison, medicine should be made available. And this was occurring, discussion was occurring in February 2020. Unfortunately, pandemic corona came in. Otherwise, the Supreme Court was hearing this petition continuously to know how the mental health inside the prison can be improved. And coming to the rehabilitation, coming to the last part of my presentation, see the mental health problems which were striking is suicidal attempt, deliberate self-harm, which is a biggest problem, because if these deliberate self-harm may be because of depression, many a time it may be a manipulative behavior. They want to get the things done according to their wish and will. That becomes a big issue. Sexual offenders, there is no cognitive behavioral therapy or any therapy is done inside the prison. High-risk sexual behavior which occurs inside the prison is not addressed, and which goes into the community, and the same thing appears. Aggression, violent, anger management is not been discussed. And many a time in the prison, because the lawyer has not come, family member have not come, many of these prisoners do food refusal, go on hunger strike, and they use various methods to feed them. Personality problems, maybe antisocial personality disorder, and even it may be even borderline personality disorder. These one or two people inside a barrack can create havoc inside the prison. So these people need to be identified and kept in a very what we call it as a controlled environment. And the other barrack should be kept with the general prisoners who are well to what we call it as mentally healthy, so that they can be dealt in a rehabilitation way. The other bigger issue was family and social reintegration. This was a big issue. The reason being is during our study only what happened was there were many raids were done if you remember in 2009 and 2010, these the dancing inside the pub was considered as illegal. Many a time the police raid occurred using the bar and restaurants, and these young girls were arrested. They were taken to the prison. The urine test was done, and their crime was that they were dancing inside the bar and restaurant. So these bar dancing girls were arrested, and those again, once they are arrested, reintegration into the society was difficult. And many a time the bar owners felt that these are the girls who leaked the information to the police, so that social integration was difficult. The man is accepted after the crime with the difficulty, but the family accept. But the woman is not accepted in our family, in our society. A woman who has committed a crime goes to the prison. Once she comes back, neither the family, their children, or the husband or the spouse do not take. Vocational rehabilitation is another big issue. Invariably, they end up committing crimes. And implication, this is not just a prison study. It has a larger implication in juvenile homes, MR home, destitute center, reception center, detention centers, social service complex, beggar colony. Rehabilitation for persons with mental illness is a big issue inside the prison. Already they are having a double disadvantage. One is that they are a prisoner or they are a custodial care. They are in there, and also the mental illness. This double disadvantage creates a major problem, and bringing them back to the society is very difficult. Many a time these patients who have been diagnosed as severe mental illness, they go into the prison. The family members are very clear. We don't want them. Let them be inside the prison. and as per the CRPC, one of the family member has to give in writing, they will look after them. None of the family members would like to come forward and give in writing. And invariably, they languish in prison for many years. One of the best example I can give is Macha Lalung, the case which came in 2005 in front of the Supreme Court. He was languishing in prison from the age of 21 to the age of 76. He stayed in the prison for 51 years for just what we call it as grievous injury. For a grievous injury, he had acute psychotic breakdown. He injures his colleague, who was a construction worker. He is taken to the prison and forgotten. He is inside the prison for next 51 years. So at the age of 76, a NHRC, National Human Rights Commission, the inspector goes in and asks him, who are you? Why are you here? He says, I don't remember. I came when I was young and I'm here inside the prison. So he was Macha Lalung, and finally the Supreme Court has to release him at the age of 76 or 78. Unfortunately, within 3 years, he expired, and they were able to, with the difficulty, they were able to trace his family, who was a younger sister. And that's the plight of persons with mental illness inside the prison. Coming to the recommendation, at this point of time, we have to implement all national health program inside the prison. Otherwise, the prison is left outside and there is no any mental health care to occur. Independent health system need to be developed in prison settings. Many of the prisons, it is basically ad hoc basis. The health doctors have been shifted to the prison. Many of the doctors may be voluntary, and many a time these doctors have been sent as a punishment to the prison posting. So that's unfortunate. But unfortunately, we require to have a separate health system. Advantage is also there, disadvantage is also there, and there is a role of psychiatrist, train the prison medical staff, training of the prison staff also, and we have to go and start peer counseling. That's where we have to start a gatekeeper suicide prevention program inside the prison, so that the many convicted prisoners will provide care to their own, the people who have been arrested recently and who lost the bail or lost the case to be provided. And we have to utilize the resources from district mental health program and also district hospital and medical college. And there is, at this point of time, we need to have a prison psychiatry to be started. In this regard, the NIMHANS Digital Academy is planning a certificate course in what we call it as a certificate course for prison psychiatry, which will be started shortly. It has been presented in front of the board of studies in NIMHANS, and in shortly it will be a certificate course for 3 months. What we have discussed will be discussed in detail for all doctors who are going to work in prison, so that we are able to provide mental health care in the prison. Conclusion: there is a high rates of mental illness in the custodial care. Need to assess for both physical and mental health status when they are getting in, and periodic every 6 months we have to do. And there is a need for independent health system inside the prison department. These prison reports are available in the nimhansco.in. These are the reports, and executive summary is available. And this is again a review of the study which is available. This study made a landmark difference in the Supreme Court judgment, and also which became a part of our Mental Health Care Act, a schedule of the central rules where we have given the direction for the prison how to improve. And if you would like to have various, what we call it as YouTube studies, YouTube presentation which is available, you can go to this YouTube, see Suresh Bada. You can find all some of the YouTube's recent telemedicine related, legal issues related, or COVID related, some of the videos are available. Please do watch and subscribe the channel. Thank you very much. So we can now take the question.
So thank you very much for the presentation, sir. We already have a few questions in the chats which have come up. Is there a difference between remand home and sentence prisons in India? This is from UK. Here in UK, we see more morbidity in remand homes.
Actually, see, the remand homes, we have a different setup. Remand home, basically, we have simply prison and jail for adults. These remand homes kind of things will be coming only in the juveniles. So it may be called as remand home, it may be called as juvenile home, it may be called as a care for home. So there are various names have been given. But for the adult population, there is nothing called as remand home here. So both UTP and CTP are kept in the prison population in India. But there is nothing called as a high security forensic setting in India again. However, in UK and US, there is something called as high security forensic. Those are not there. But however, it's high costly, and over a period of time, now they have realized to have these even mentally ill patients along with the general population of the prison, inside the prison, so that they are not discriminated. Otherwise, we will be discriminating these persons with mental illness, prisoners inside, again telling that high forensic setting will be discriminatory. But however, currently we do not have that dichotomy of remand and the prison separately.
So how long was the training given for the prison staff?
So the first and the foremost is there are two things. One is research staff. The research staff had, which we hired them in our study, where they undergone for first 1 month, and then the 1 week they went to the prison to get the feel of it, and they again came back, and there was again the training continued for another 15 days. Later, in between 6 months, again there was a refresher training course was done. That is about the researchers. Coming to the staff were trained for 1 week. So they were chosen who were from the psychology background, who were volunteering to do what we call it as these kinds of rehabilitation, and they are psychologically oriented or mental health related oriented. They were taken for this training program, and 1 week training program was done. And for the CTP prisoners, for gatekeepers training program for suicide, or what you call it as convicted prisoners, they were trained for half a day training program was done with related to suicide prevention, with assessing or looking for depression and substance use. So this was for half a day for convicted prisoners.
So, should all chronic psychotic patients in the prison shifted to psychiatric hospital as a rule? Many times Human Rights Commission visits insist so, for which Dr. Pratish Thakur from UK has mentioned that in equivalence of care in UK, the prisoner's illness is that if it is of that nature and degree that requires treatment in the hospital, they're usually transferred. Chronically ill are not transferred unless they meet the criteria for admission. So what happens in India?
This is an interesting one. There is a Supreme Court judgment also telling that shift all the prison persons with mental illness from prison to mental hospital. Unfortunately, if you look at our mental hospitals, they're already overcrowded, and not more than 26,000 beds are available, and all these beds are already overcrowded. Shifting these severely mentally ill, in recent one of the studies said that it is around 7,000. If you shift 7,000 population from prison to mental hospital, we require escorts, which is very difficult to manage in the mental hospital. And these 7,000 beds which are utilized for general population, imagine, see, 1.3 billion population has around 26 to 30,000 beds in mental hospital. So giving it for 6 to 7,000 prisoners maybe looks attractive, but it's not the way to go around. The best way, what we planned is, especially in the Bangalore prison study also, there was a barrack which was converted for the mentally ill patients. Dr. Rajini was the initiative, and the IG prisons, Dr. S.T. Ramesh also supported this. That barrack was considered as a barrack for psychiatrically ill patients. The medicines were given by a trained person, and later the nurse was hired, and the medicines were given in the morning, afternoon, and in the evening. Earlier there was no such mechanism was there, and later that mechanism was brought in, and so that the barrack was where the patients were treated there only, and who were severely ill, who required certification, were only shifted to mental hospitals, and it was only for a duration of 1 to 2 months or 3 months maximum, and later they are shifted back to the prison. So here we do not have that separate forensic setting kind of thing, and hardly in few of the mental hospitals we have, and the district hospitals, very few of them cater for these kind of population. Medical college do not have much of them. Very few of them provide forensic psychiatric care. Still forensic psychiatry is in the budding stage in India. Over a period of time, it may grow into a bigger, what we call it as a specialty.
But can one psychiatrist handle, say, 5,000 plus prisoners in Bangalore prison?
It's simply impossible. Dr. Rajini single-handedly was able to manage for nearly, I think, 6 years she was running it. Every day she used to see something around 100 to 120 patients. Many a time, whenever there is a court order, she used to send it. We had a liaising, and she used to send those patients to NIMHANS. A single doctor will not be able to do any justice. most of the time she was writing medicines, and with the patient who has attempted suicide or who was contemplating or pre-contemplating suicide, those were the patients she was able to spend time. But however, now the Karnataka prisons department has come up with, I think, 20 psychologists, and they have even advertised for the psychiatrist in prison. Hope those vacancies will be filled, and the numbers required actually, we have advertised for every 500 prisoners we need to have one psychiatrist. For that, for that number, it should be 6 psychiatrists should be available for 5,000 prisoners. That should be the way to go ahead.
So, there is one postgraduate student from Hyderabad who has asked that she is doing a dissertation on psychiatric morbidity among female prisoners, to guide her in the scale to be used to assess, to preferably a free scale, and some important points to ponder upon while doing the study. So should we ask her to contact us or email? And
I think that would be fine. But however, in female prison, in any kind of this study, the support from prison is very, very essential. If the prison staff do not allow you, you will not be able to go. And you being a lady, access to the prison, so the barrack, woman barrack is easy. But however, it should be a bi-directional. You have to study. At the same time, you should also discuss and do the prison staff training. Otherwise, the prison department will not gain anything, and they may not allow you to go inside the prison. And also, they do not want to wish to disclose their prison settings, what is happening inside the prison. So invariably, it's a difficult study you have embarked on. But however, if the prison department is very cooperative, it's worthwhile doing a study. Please do contact us or separately. I would like to discuss this interesting study what you are embarking on.
Substance-induced disorders is high compared to DSH in prisons. How to address this issue?
Of course, it's a when the study was been happening, suddenly there was the staff of the prison became highly alert. The substance was not allowed inside. There was then the availability of the substance like cannabis became very low, and the whatever the substance cannabis was available was very less. During that process, there was a fight inside the prison for availability of the cannabis. One person actually took a stone and killed another person for the sake of cannabis. The violence because of substance use is very high. There is no doubt about that. That's the requirement of de-addiction inside the prison is highly recommended at this point of time. One is one is de-addiction, HIV clinic, tuberculosis, anti-tuberculosis program has to be implemented the earliest. And now, of course, because of coronavirus, there have been here and there outbreaks have been started inside the barracks of the prison. And now, though the court is not functioning, sometimes the prisoners are taken inside the prison. And if we don't, screen them for coronavirus, there may be outbreak inside the prison, and the senior citizens inside the prison may catch the coronavirus, and it will be very difficult to control. So the health inside the prison need to be given priority, although outside also is required. And now the public health has to be implemented even in prison, because they are not going to be staying in the prison for longer duration. They'll come outside. They need to be rehabilitation, not only in terms of vacation, and health also is a very essential ingredient.
So how about non-suicidal self-injurious disorders?
This is again, the majority of the time we found that it is a manipulative behavior. When his or her wish is not being fulfilled, they do manipulate, and many a time they may be either deliberate self-harm because of borderline personality disorder, or it may be, majority of the time it will be of antisocial personality disorders. So at that time we have to document, we have to treat them as an emergency initially. Over a period of time we are able to document and say that they are manipulating without challenging them. We need to have a structured environment. They have to be placed in a barrack where the structured environment is well managed. The prisoners and staff population is slightly at higher stage. They can be structurally monitored. In those situations, especially, these people need to be monitored. Otherwise, they will take us for a ride actually, and it will be very what we call it as a taxing for the prison staff when these kind of population, they are hardly very few, 15% in number, but they are the one who are going to create a mess inside the prison. Otherwise, rest of the 85% are people who wants to reform, they want to come outside, lead a normal life. So these 15% of the personality disorder need to be dealt very what we call it as a structured way. There the mental health professionals requirement is very high.
What are the possibilities for an NGO to intervene in such
This is
situations?
again some of the prisons are very open for NGO, some of the prisons are not. It's a discussion which has to be started, initiated, and then the what we call it as a prison department do not many a time do not trust NGO, and many a time NGO wants to expose a lot of things inside the prison, and then it becomes a what we call it as a tug of war, and then the licensing goes off. So the NGO needs to work inside the prison, because that is the only way. Like in a mental hospital, the NGO is required. Similarly, even inside the prison, also the NGOs work is required, and then that's going to change the equations inside the prison. Human rights violations also can be decreased, especially for persons with mental illness.
Sir, in India, do the courts ask for reports from psychiatrists on issues like psychiatric defenses, insanity defenses, fitness to plead, also for sentencing, parole hearings? And Dr. Pratish says that he's disappointed to know that there is no psychological programs running to reduce the risks.
Yeah, Dr. Pratish, I do understand about this. You're talking about psychiatrists. The availability of doctors are not there. Many doctors do not want to go to prison, and whoever the doctors are there, maybe 4 or 5 in number, they'll be catering for a population of 5,000, 6,000. So they're also overworked. They will be just prescribing the medicine rather than involving in any kind of psychosocial rehabilitation. That's the I would like to go about the answer. And
what are the journals in India where we can get prison-based study easily published?
Indian Journal of Psychiatry. If you look at the Indian Journal of Psychiatry, has published 2011. There is a title called as Prison Psychiatric Morbidity in Prison. The same title, 3 or 4 studies are every year it has been published. I request all our psychiatrists to publish in open journals like Indian Journal of Psychiatry, so that the findings is available. Don't go for a journal which is maybe international, but you have to pay $25 to access those journals. Don't do that, because these are all precious data which can bring about policy change in what we call it as in India. The prison study published in somewhere in the European journal, will it have an implication? I have a serious doubt. But if it is published in Indian journal, it is freely available, because if you look at the Indian journals, majority of them are free. So you can access that, you can cite that, and also policy changes can be brought in. Over a period of time, earlier I was also skeptical, what is this Indian journal? But now I am very, very hopeful. Our Indian Journal of Psychiatry has got a high impact factor now. It's now crossing 1.3, 1.4. Over a period of time, it will do well. And of course, these kinds of policy papers need to be published in national journal rather than the international journal, because of the accessibility of this data.
Prison departments have asked to open a psychiatry ward inside the prison itself. We have to admit and treat the patient there itself. What about ECT, depot in such cases?
Yeah, of course, it depends upon the psychiatrist inside the prison. If he wants to give ECT, worthwhile having a review board inside the prison, or else if you find that ECT may be considered as a stigma inside the prison, don't give ECT. But however, injection can be given, oral medications can be given. Whenever a person requires ECT, if he's so severely ill, worthwhile referring them to nearest mental hospital for care.
What scale did the study use to test malingering or manipulation?
This is a part of what we used was the same scale what we used. Mini also has a malingering, for the antisocial personality disorder, there is a scale available in that. So that the same scale was used, and it was translated into Kannada language, and then it was used.
Sir, Dr. Senthil Kumar has said that when we see prisoners convicted for homicides, but history during our evaluation shows clear post-ictal confusion or delirium tremens during the time of offense. The innocent prisoners are now suffering with severe secondary depression. We find ourselves helpless. How to proceed?
This is again very common. If you look at one of the, it's like this: all substance users are not criminals, but many of the heinous crimes are committed under the influence of substance. So many a time we may say there is no relationship between substance use and the crime. There is no one-to-one relationship. But however, heinous of the heinous crimes are occurred under the substance use. So many of them, when they commit these such crimes, it may be murder, it may be rape, it may be what we call it as the various even terrorist activities are also done under the substance use. So we need to know that there is a link, but that is the reason we have to have a de-addiction center inside the prison. Without de-addiction center, whatever even a single psychiatrist will not be able to do, a full-fledged de-addiction program has to run inside the prison. It may be for tobacco, it may be for substance use like cannabis, opioid, alcohol, and like earlier I never had this kind of thinking of association between crime and substance use, but now as I go on studying more about the forensic psychiatry, I'm becoming more and more convinced that substance use also have a role to play. A person under intoxication is a completely different person. Once he is sober, he's a completely another man, so or a woman. So we need to be have this de-addiction program running, to have this rehabilitation center. Otherwise, a single psychiatrist or two psychiatrists inside a huge population, they may not be able to do. And it should be a peer counseling should be planned. AAA should be possibly brought in inside the prison. Various other psychosocial rehabilitation should be planned.
There is an interesting question that is mental health establishment license is mandatory for prison hospital according to MS?
Of course, wherever a person with mental illness is kept, apart from his residence, has to take license. There is no license, means registration here. There is no licensing under Mental Health Care Act. It is registration. They have to undergo registration, or else it can be dealt under the state rules telling that all these prison facilities in one of the barrack will be considered as so and so, and the registration is by default can be considered. That's how the state rules has to be modified, or else all prisons wherever the mentally ill patients are kept, they have to get registered.
And as an extension of that, also will be coming under the purview of mental health review boards.
Yes, of course, they have to come. They will under the mental health review board. Yes, of course, there is a review board. These review boards also will help us inside the prison to rehabilitation purpose, or the requirement of medicines, or placement of the patient. All those things can be planned.
So juveniles in conflict UTP or Boston homes are not regularly sent or asked for psychiatric evaluation. Only a few districts follow this. Any suggestions on
Dr. Senthil, I think this is a very interesting question. Wherever the JJ board has undergone training, or CWC has undergone training, they are doing it, and many of my fellow psychiatrists are overwhelmed. Every week they are getting referral telling that this young boy has done some crime or heinous crime. They have done the Eve teasing. They have used MMS. They had a consensual sexual activity under POCSO. They have been charged. The numbers are increasing actually. Sometimes ignorance is bliss. Some of the JJ board or CWC, that is Child Welfare Committee, have not been trained. There the referrals are less. Over a period of time, this will increase. And if it increases, the psychiatrists have to be on the toes. I'll give examples. In some of the CWC or JJ board, they have forced our psychiatrists to sit there in the JJ board, providing care for those juveniles. Assessment have been done inside there only, and many a time many of these psychiatrists have called me and asked, how can they force us to do the evaluation inside these JJ board or inside the CWC? Many a time they are oversensitized. In some places they are not sensitized. It's a time. It's slowly it will take, and it will be implemented.
Dr. Sabina Rao has asked, violence is common towards mental health professionals. Any self-defense training is required in forensic settings?
If you are not in forensic setting, in any psychiatric setting, of course, the mental health professionals need to undergo training. One is self-defense, of course. At the same time, many a time, men can defend, women also, some of them can defend. But if the person with severely mentally ill, especially in forensic psychiatric setting, not to take that risk of defending yourself, need to have adequate escorts when you enter the prison. Even inside the central prison, I had gone many times as a researcher. There also we need to have escorts, because many a time there may be some violences which can be erupted very suddenly, which is very difficult to predict. And so at that time, your self-defense may help to some extent. The escort is required.
if I can add to that, it is common everywhere. It's not only in psychiatric setting.
Of course.
It's present in general medicine, general surgery. Everywhere, violence against another human being, especially doctors, is present. Self-defense helps, but the first and foremost self-defense for a psychiatrist is our communication.
Yes.
If our communication is good enough, and if we are able to pick up things, sometimes escorts are outside, and we need to intimate them immediately so that we are also safe.
Yeah, true, Dr. Chetan.
So, she also has shooting of quetiapine IV in the US in prisons. Something to think when opening mental health centers in India.
Quetiapine, I think IV is not available in India, but however, availability of even injectables, flufenazine available inside the prison of the Central Prison Bangalore. But slowly, I think DMHP has brought in Respiridol, Consta actually. Respiridol, not Consta, Respiridol long acting is available now. Has been made available under the National Mental Health Program, basically under the Mental Health Care Act section, I think 23 or 22, where the essential medicine should be made available for all the patients. The Respiridon is there, so but quetiapine has not been mentioned. So, but however, these policies can be changed over a period of time, and it is under the bureaucrats' hand. Quetiapine, if it is available, can be brought in.
So how to address substance dependence if inmate refuses for de-addiction program? Can they be forced?
You cannot force any de-addiction program. It has to be basically they have to go through the same whatever pre-contemplation, contemplation process. Any amount of force, the day when you use force, the rehabilitation is not going to work. And even if NDPS Act is forced there, a person is using cannabis, you can put one more case against him. But will it serve any purpose? It's not going to serve any purpose, because if you look at the WHO, earlier I'm talking about, WHO used to say that this is an economical offense. A person who is using definitely drug abuser or drug user, punishing them is a human rights violation. That's how the international human rights societies talk about this. At the same time, a person who sells drugs, of course, it has been considered as a serious crime, and that's again economical offense. There are many people who take loan and they run away from the country. That's also an economical offense. So a person, so should it be used a different way of managing them? That's a debatable issue which needs to be taken into consideration. And I think this is a larger picture which has to be addressed in a policy setting. And it's a very disturbing to know that many of our substance users are still punished under NDPS Act, and they have been given 6 months imprisonment for using cannabis. Or although it's a moral judgment what we take, but however, instead of imprisonment, they require rehabilitation, de-addiction treatment. Maybe I don't know where it should be situated, in the inside the prison or outside the prison. Availability is an issue which needs to be discussed and implemented at the earliest.
Thank you, sir. We come to the end of the session today. Before we end the meeting, I urge all the members who are present here, and also tell your friends to subscribe our YouTube channel, NIMHANS Indians. The link is given in one of the chats, so that you can access all our videos, all our sessions in the YouTube channel. We also like to place our sincere gratitude to Linux Laboratories for their academic grants by which we are running this program. So thank you very much, sir.